right. መጀመር ይቻላል ዶክተር።
እሺ okay. Thank you, the BCD company, for organizing this event and for giving me a chance to present about this topic on hepatitis. So I'll be talking about hepatitis B virus, and with this COVID-19 situation, I'll try to discuss the effects of the COVID-19 and the chronic liver disease. So I am Hailemichael Desalegn from St. Paul's Hospital, and I work here as a consultant and internist gastroenterologist. So I have no conflict of interest to make, and as COVID-19 is a new thing, no one is, as you know, expert on this field, and so I'll try to review literatures that will strengthen the evidences for COVID-19 and in its relation to the liver disease, especially to hepatitis B virus. So I'll discuss about first on hepatitis B virus, and as you see here is hepatitis B virus picture. Mainly I'll discuss on as an advocate, I'll try to show the burden and the neglected pattern of hepatitis B virus, and some updates from recent release of the WHO guideline, which has been released on July 28th. Actually, it was about mainly on prevention of maternal to child transmission of hepatitis B virus. I'll try to say something about the July 28th release of WHO hepatitis B virus guideline. And finally, I'll discuss about COVID and the liver evidences, how chronic liver disease will be one of the patients will be vulnerable to COVID-19 and its complication, and how COVID by itself affects also the liver, and in the general care, and also how COVID affects patients with liver disease. Finally, I'll try to recommend from the whole points that will be raised. So hepatitis B virus, as you know, it is one of the most ubiquitous virus, which has, as you see, partially double-stranded DNA. In this beautiful picture, you can see the surface antigen, the different forms of the surface antigen, the large, the medium, and the small, which has been depicted here. You can see the core and the polymerase, and also you can see the partially double-stranded DNA inside. So the most important or the peculiar thing of the hepatitis B virus comes actually into its life cycle, as you see in this picture from the JAMA. The life cycle of hepatitis B virus comes into these different steps in the hepatocytoplasm and also in the nucleus. The most important landmark in the hepatitis B virus treatment and also in the management comes after the advent of the entry receptor, which is the NTCP, as you see here, which is a sodium taurocholate co-transporting polypeptide, which is important for binding and entry via endocytosis. So this entry inhibitors has been now developed and has been on assessment for both hepatitis B and the Delta infection, because these viruses use the same receptor for entry. After enter, it then cause uncoating of the virus with the hepatitis B virus polymerase and the relaxed circular DNA, which we have seen, which is a partially double-stranded DNA, which will enter the nucleus. The nuclear entry is with the relaxed circular DNA will be changed into two steps. One is it undergoes integration into the host DNA, as you see here. And the second step, which is peculiar, is also a DNA repair in which is a partially double-stranded DNA will be changed into covalent nucleocircular DNA, which lead to the persistence of the virus. The current available drugs will not target this covalent nucleocircular DNA. That's why there is no actually cure for the hepatitis B virus, and patients are left with lifelong treatment because the covalent nucleocircular DNA actually mainly remains in life with the current available treatment. And the next step is transcription, in which the DNA will be changed into the RNAs, the pregenomic messenger RNAs, and then this comes out into the nucleus. Then further process, which is normal up to here, which is translation will occur and formation of the different proteins. Then comes one other peculiar thing, which is a reverse transcription, in which these RNAs will be again formed. The partially single-stranded DNA molecule will be formed, and this is also another site for target, the only treatment option that we have widely available now, in addition to the host inhibitors and also the interferon is a reverse transcriptase inhibitor. So this is the target, inhibiting of the RNA into single-stranded DNA synthesis production. And then after that forms a complete DNA structure. And there is another peculiar thing also. So we have seen formation of covalent closed circular DNA and then reverse transcription. And then also occurs recycling that further increases the pool of the virus inside the nucleus. So recycling occurs from this double-stranded DNA and then into relaxer circular DNA into the nucleus. So this forms actually a continuous pool for the hepatitis B virus to circulate and to remain inside and to persist despite giving the common drug that we are using, which is a nucleoside or a nucleotide analog. After that, there is envelopment and exocytosis will occur and release. And probably the formation of the hepatitis B E antigen is also another step which occurs in hepatitis B. This envelope antigen, envelopment with the surface antigen also to exocytosis. So the most important part, as I've said, is that leads to the persistence of relaxer circular DNA formation into integrated and also equivalently closed circular DNA. So if you see the burden of the hepatitis B virus, the WHO estimates in 2015 alone, around 3.5% of the world population is living with chronic hepatitis B virus. From this, 68% are mainly in African and the Western Pacific region. And when you see the co-infection with HIV, around 2.7 million persons will be co-infected with HIV. There are policies and there are free drugs available for HIV when they are co-infected. So these 2.7 million people are the ones who get free treatment with nucleoside analogs, as you know, and there is no free treatment for those with hepatitis B virus infection. Those who are infected alone do not get free treatment because there is no support, there are no partners which support the viral hepatitis program. Even though the burden is high, as you might see, still there is no strong support, global support for hepatitis B virus. That's why I have said I'll try to be more of an advocate also to show the burden of the disease. So this is a picture showing the global prevalence, 257 million people. As you see, Africa is, sub-Saharan Africa mainly is having around 60 million infection with viral hepatitis. This is from the WHO estimate. And when you see the pictures in the different virus, hepatitis B, HCV, and HIV, you can see that hepatitis B virus comprises around 257 million compared to 71 million of hepatitis C virus infection and the HIV. And why we say it's neglected, you can see this this study, which is published in the Lancet. They published in the PLOS actually as a neglected tropical disease. You can see that the funding and the number of publications compared to HIV, malaria, hepatitis C, and hepatitis B virus. Starting from 2013 up to 2018, the number of the funding on summary is around 1% for Hep B compared to like 89% for HIV. And also the publications are also like 3% for hepatitis B virus compared to a big picture for 77%. So this study in the PLOS, they said that it fulfills what we have been saying as a neglected disease. Despite its burden, despite patients are dying with increased mortality, but the funding and the publications are also very, very, very minimal. So you can see the mortality in 2015 alone, around 1.34 million deaths are incremented to viral hepatitis. These deaths are comparable to actually tuberculosis in that time, but it was really higher than HIV and malaria. And the number of days due to viral hepatitis are actually increasing over time. One data that shows that the mortality has increased by 22% even since 2000 is really an alarming data. So you can see in this schematic drawing, which is published in the New England Journal of Medicine, you can see HIV was really high in the 2000s. So when there are no partners, there are no supporters or funders, there is no awareness at that time, no diagnostic capabilities, the HIV was also increasing exponentially until then it comes to drop down, as you see. Further support, further awareness is also still important for all diseases, but for hepatitis, with the current trend, if you are continuing, it will be like as in 2014, it will be the number one cause of deaths in millions, as you hear, for both hepatitis B and hepatitis C viral infection, compared to tuberculosis, HIV infection, and malaria. And WHO has this ambitious goal, and this ambitious goal of WHO proposes that to eliminate hepatitis B virus by 2013. What does elimination by 2030 means? So 90% reduction in the new incidence of infection, and also 65% reduction in mortality. We are now in 2020. This guideline has come out, like I see, from 2015, if you see, but we haven't reached to such a target. Actually, it means active hepatitis B virus prevention strategies. 80% of people eligible for treatment should be treated to reach this target. And this requires identification and linkage to care. But on the reality, hepatitis B preventive strategies are scarce, especially in sub-Saharan Africa. And those eligible individuals are actually not diagnosed and also not treated. So this needs a wide spectrum, I mean, collaboration with multiple parties to reach to such kind of targets, to diagnose, to increase awareness, so that those who are aware will be diagnosed, and those diagnosed will be linked to care, and this linkage to care, and then also follow up. So this is very important to reach this ambitious goal. You can see the deaths from viral hepatitis, it's mainly the hepatitis B virus as the main cause of hepatocellular cancer and cirrhosis. Some acute hepatitis B virus could also lead to mortality. Hep C, also due to cirrhosis and hepatocellular cancer, is also an important cause of death. You can say E, acute hepatitis, mainly in pregnant individuals, is a major cause of mortality. As you know, hepatitis E virus in pregnants are infected, it could lead to 25% mortality. Hepatitis A is really minimal compared to the other viruses, mainly causing acute hepatitis B. As I've said, access to testing and treatment is limited. And it's from studies have shown that only 9% of hepatitis B virus infected persons are diagnosed. So 91% of individuals are not diagnosed. Because hepatitis B, in general, patients with chronic liver disease are usually asymptomatic, and when they are having symptoms, it's actually late, unless an increased awareness, increased testing needs are increased, we will not reach to this target. So that's why the World Hepatitis Alliance, one of the aim or the themes was find the missing millions, because this means around 290 million people are not diagnosed. Yet they are infected, they are not diagnosed. They are highly likely to infect others and likely to come also with complications. So only 9% of individuals are diagnosed. And from this 9%, it's not from majority or from all, but from 9%, only 8% are on treatment. So this is really a small amount or limited amount of numbers who are on treatment. From 9% of the individuals, only 8% are on treatment. So this is the service coverage indicators. So one of service coverage indicators is hepatitis B virus vaccination. Hepatitis B virus prevention of maternal to child transmission. I'll share you the updated guidelines. Blood safety, injection safety, harm reduction, testing service, which I have said 9% of individuals are diagnosed. And Hep C, 20%, and on treatment, around 8% are only treated in patients with hepatitis B who are treated from the 9%. The goal is to reach 80%. In Africa, we have been collaborating with a Prolifica team, a Polaris observatory team, actually. It has undergone hepatitis B virus modeling. This has been published on LANCET. So sub-Saharan Africa, so we have also submitted data and expert opinions from different parts of the sub-Saharan Africa. And you can see that 78 million are estimated to be hepatitis B virus infected. From this, 27% eligible for treatment, and only 2% are diagnosed, and only less than 1% have access to therapy, and less than 1% pregnant women are treated. And this is especially a huge gap, especially in pregnant women. You will see they are not actually, treatment has not been given. I have tried to see there's no treatment in pregnant women, screening and treatment also, screening and treatment and prevention of maternal to child transmission during pregnancy is scarce. In 2015, 87,890 cases in 2015 has occurred in relation to either acute hepatitis B, chronic hepatitis B, and its complications, like complication of cirrhosis or a cancer. And this is also an important slide, which is clearly showing the need for prevention of maternal transmission. Maternal to child transmission is very important. You can see hepatitis B virus around 360,000 estimated infants perinatally infected with hepatitis B virus compared to HIV. This has been published on elementary pharmacology. We know that there is strong programs for prevention of maternal to child transmission of HIV, but not for hepatitis B virus. Yet the number shows that it's really high number of individuals are actually infected perinatally. This number is really high, especially in sub-Saharan Africa, because this perinatal transmission is also high. And the vaccine has shown that it's quite effective. You can see this is a study in Taiwan. Actually, our landmark studies for hepatitis B virus are mainly in Taiwan. We can see that they have a cohort studies that had been running for a long period of time. And they have seen that after the vaccine has started, there is a decrease in service antigen prevalence from 10%, which was in 1984, to 0.5%. So this is a huge decrease has occurred by giving vaccination. And chronic liver death and mortality has decreased by more than 90%. And incidence of cancer, hepatocellular cancer, has decreased by more than 80%. So this from the Taiwan study. There is a big cohort of studies that we use as a landmark, especially the REVEAL study, which has also helped in formulating of guideline which individuals are likely to progress to cancer. So that is the landmark study has been from the Taiwan study. So it has shown also that this Taiwan study have also shown vaccine importance of the vaccine. There are also another study in China. They're also giving like a birth dose vaccine. A huge benefit has been seen by birth dose vaccination. So it has been included as a performance indicator. And then this birth dose should be followed by 2 or 3 doses of the hepatitis B vaccine. And all pregnant women should be tested for Hep B surface antigen at least once and as early as possible. You know that this has also included like syphilis and others, but they also give a strong indication to screen all pregnant women for Hep B surface antigen. And then if the mother is known to have hepatitis B positive, and then if the viral load is more than 2000, tenofovir is recommended. So 28 weeks until at least the birth, it should be continued. So there are different scenarios like 4 weeks or 6 weeks of therapy, but this guideline recommends it should be continued until at least birth. Let's see the algorithm. So if the mother, pregnant mother, is Hep B surface antigen giving a test, and if she's positive, we check viral DNA. The other good thing for resource limited settings that I have put it, if viral DNA is not available, we can use the E antigen label. The antigen can also replace viral DNA in these scenarios, and we assess for cirrhosis. So in then we have 3 scenarios. The viral DNA may be less than 200,000, or E antigen could be negative and the mother is having no cirrhosis. In this case, we don't give maternal tenofovir and we defer long-term maternal treatment, but we should monitor this mother, and the infant will be given a birth dose within 24 hours, and then 2 or 3 doses of the API program. Actually, he can continue with that. But if the mother has a viral load of more than 200,000 international per ml, or if it's not available, like if the mother E positive, okay, and if she has no cirrhosis, then we need to give maternal tenofovir for prophylaxis to prevent the child infection. So we start from 28 weeks and continue at least until pregnancy, at least birth. And we reassess her for like maternal tenofovir treatment after labor, so that whether she needs a treatment criteria for lifelong treatment. And then the hepatitis B birth dose will be continued. If the mother is having a very high viral load, signs of cirrhosis, persistently abnormal ALT, this patient may need tenofovir treatment and you may need to continue for her benefit also. Like this patient may progress to cirrhosis or cancer. So if she has a treatment indication criteria, we will give her treatment. But if the mother is E positive or having a viral load of greater than or equal to 200,000, treatment should be started with tenofovir treatment. So when see hepatitis B in Ethiopia, actually we have a population estimate of around 140 million, it could be even higher. The estimated meta-analysis have shown that hepatitis B prevalence is around 7.7 Sub-Saharan Africa, the country burden. We can see that it's followed by Nigeria. These 2 highly populous countries in Africa are having the highest burden also in Hep B and also in hepatitis C virus. These countries are actually, when you also see Ethiopia is among the top like 20 countries in the world, which actually are increasing the burden with an increased burden of the hepatitis B and hepatitis C virus. So partner support, menstrual support, and civil society support is very, very important to curb this epidemic situation. For instance, the natural history, the birth dose is important because those who are infected at birth are actually the ones who are likely having 95% risk of having chronicity, as we have been discussing. So hepatitis E antigen negative mother or from E positive, when the patient has chronic hepatitis B, there is a 30% chance of having a chronic infection, and then a 40% chance of having liver failure, cirrhosis, or cancer. And the risk factors acquired early in life, actually. Early childhood has been showing the major role of infection. Even a study by the famous Professor Hailemichael, who has done a lot of work on viral hepatitis, he has shown that early childhood infection plays actually the major role for hepatitis B virus. Hepatitis B virus and hepatocellular carcinoma, we have tried to show in this study what's peculiar from hepatocellular cancer from others, or hepatitis B from hepatitis C associated cancer. So this is an African liver cancer consortium. So the countries which have been included are like Ethiopia. We have contributed some cases for this study, and also other countries have also been included from the West, Africa, Tanzania, Uganda, and Sudan. And also we have compared these studies from Egypt. Egypt was peculiar in that it has mainly hepatitis C virus infection, and the other countries, the predominant cause was hepatitis B virus. And what comes was, when to the clinical characteristics, Egypt and other African countries were quite different. And you can see that cancer at the age of accusation was younger in Ethiopia and other African countries. It was younger by more than 10 years. The median age was 46. And liver cirrhosis was present in only 66%, like in Ethiopia and other African countries. But in Egypt, almost 100% of individuals were having cirrhosis when they have cancer. But in these individuals in other African countries, they don't have cirrhosis. They could have a normal liver parenchyma and they develop cancer. Another important thing is also in the laboratory data, alpha fetoprotein, what the median was around 139, as you see here. It was like 6.5 to 1011, but it was higher alpha fetoprotein levels in the other countries. So that means these individuals also they mount low alpha fetoprotein, and the cancer was mainly multinodular, 84%. So actually it makes it difficult to diagnose. If it's multinodular, ultrasound sensitivity could be poor, and alpha fetoprotein, if you rely on that, the sensitivity is also poor. But individuals are having cancer without cirrhosis, almost 40% individuals, and it occurs at younger age. So this is really associated with also a dismal prognosis. But we have also shown here that treatment is, this study which has been done at St. Paul, and we have shown like a 1-year result. This was published on BMC Medicine 2018. We are trying to show that we can start hepatitis B virus treatment, and the treatment response, the virological response to therapy, and also the fibrosis or liver stiffness improvement could occur in these individuals. And we have also shown the retention to care. There is no resistance developed in these individuals. So it was associated with a good outcome. But the most important thing is these individuals, they should be found early and need to be treated so that we can prevent further complications. And table 2 in this depicted table shows the characteristics of patients who developed hepatocellular cancer in the course of study. You can see viral loads may not be determinantal. They may have different viral loads. And ALT was, in some individuals, could be 30. Comorbid illness like diabetes mellitus also in a large cohort have shown that diabetes is also an important independent risk factor for cancer. So type 2 diabetes mellitus should be investigated in these individuals. And some points on the COVID-19 and chronic liver disease. So in addition to hepatitis C, Okay. They're also associated with the GI manifestations and also with luminal manifestations of the disease. So the gastrointestinal manifestations has been studied, and some individuals may present with GI symptoms only, and AST and ALT were both mildly elevated in majority of patients in some studies, like in the Wuhan studies. And half of the patients also report digestive symptoms. That could be also like anorexia, but also nausea, vomiting, and diarrhea will present. And some patients, like 6 patients, were having only digestive symptoms. I will not discuss mainly on the luminal part, but studies have shown that the luminal part is also an important, because the enterocytes are like more than 100 times abundant in the enterocytes, and patients could present with manifestations of the disease. From the previous SARS, we can learn that like flushing in the toilet, flushing aerosol, where is also one important cause of the transmission, and that could also be one cause of transmission of the virus in this COVID-19, like when we're flushing, and aerosolized particles might be one important source. How could be the liver affected? So SARS-CoV-2 has a direct cytopathic effect to the liver. And the other thing is, as we have seen, the immune reaction, the cytokine storm can also affect the liver, and uncontrolled immune reaction is also an important factor, and sepsis affecting multiple organs, and the liver will be affected with that. The drugs that we are giving, like remdesivir, are also associated with drug-induced liver injury, and there are also reports of liver transplant recipients with COVID-19. So COVID-19 could have a liver manifestation, as SARS-CoV-2 could also infect the liver. This COVID-19 has come just after publishing this study. This we have published on the prevalence of hepatitis, and also how many patients need therapy. We have recommended leveraging resources, and rapid scale-up of treatment is important. We have tried to show in this study. I just recommend, if you want to read, you can see that hepatitis B in sub-Saharan Africa, how many patients need therapy, like within 6 months of therapy or within 1 year, so that we can have, based on the eligibility, like if you screen patients, how many patients will be eligible for treatment, and it's in the different genotypes, and we have discussed many things about it. Just so this shows that the prevalence and these measures need to be done for hepatitis B virus prevention. And we have also shown that the treatment of hepatitis B and also the birth dose implementation could have like an economic evaluation has been done. An important, these are a group of experts with whom I have tried to see the economic evaluation of introduction of birth dose of hepatitis B virus vaccine. So it has also an economic impact. Like if we give a birth dose, if we prevent further cirrhosis and the prevention of cancer in the long term, and giving like a birth dose at this point of time has also an economic evaluation. We have tried to assess that. Why I put all this, hepatitis B is increasing. It's not yet given adequate attention. And also SARS-CoV-2 come and cause this COVID-19 disease, which drives attention into COVID-19. This affects actually those diseases which have already didn't get enough attention. That the minimal attention that they have got has also been diverted to SARS-CoV-2, like the vaccination programs, as I've said, birth dose within 24 hours. But with COVID-19, individuals are getting home births, and also those who are giving the vaccine, the programs has been shifted to COVID-19 prevention. We can see that the diagnostic machines for the PCR, which have been investigating hepatitis, will be shifted to the SARS-CoV-2 PCR tests. So this will cause a collateral damage, which we have said, which are published here on the LANCET as a converging pandemic. So implications of COVID-19 for the viral hepatitis response in sub-Saharan Africa, you can read on that. So this collateral damage may have a huge impact. We need to give attention for this pandemic, we also need to take care of the hepatitis B virus. So, comparison of mortality risk in patients with cirrhosis and COVID-19 compared with patients with cirrhosis alone, and COVID-19 alone has also been studied. This study was from the University of Michigan, Hepatology. This is from the Virginia Commonwealth University. There are also other studies from the Korean that shows that. So in this, for example, they have compared COVID-19 individuals, like 7 centers has been used, compare COVID-19 individuals versus patients with COVID-19 when they have cirrhosis. The mortality was 30%, and those who have COVID-19 and cirrhosis versus 13% in those with COVID-19 alone. And they recommend underlying cirrhosis should be considered a high-risk comorbid condition. Prevention and early treatment of decompensation. So patients with COVID-19 patients, we need to prevent decompensation. And patients without COVID should be encouraged to continue their follow-up. As I've said, patients without COVID and having cirrhosis, they should continue their surveillance so that we can treat them only when they have early cirrhosis or when they have cancer, when they are found at early stage. So it should be encouraged to have their follow-up. Another study called Secure Cirrhosis is also an open international registry. In their studies, they have found a mortality rate of 40% among patients with cirrhosis. So they have said that patients with CLD represent a vulnerable population. These are at high risk of acquiring COVID-19, and they are also likely to suffer from its complication. Different studies have been done. And the final recommendation is early admission of patients with COVID-19 and advanced liver disease. And we need to evaluate liver biochemistries in COVID-19. When there is a derangement, it could be due to viral hepatitis, it could be due to complications that occur due to COVID-19, it could be due to the drugs that are being given, so we need to look at this all together. The effect of SARS-CoV-2 and COVID-19, consideration in hepatitis B virus and hepatitis C virus. So when we have actually treatment of chronic hepatitis C virus, if patient is having COVID-19, if the patient is on treatment for hep C, we need to continue their treatment. If they are newly diagnosed, we need to defer until the COVID-19 resolves. We need to see hepatitis C virus, we need to follow them. It's not good to combine the COVID-19 drugs, or the seriousness of the COVID-19 should outweigh, and we need to follow the liver disease in chronic hep C. If the patient has no COVID-19, we need to always strengthen to treat them and to diagnose and treat. If patient has hep B, if on treatment, we need to continue the antiviral drug. If the patient is untreated and is on carrier state, we need to consider treatment to prevent flare of hepatitis B virus. In hep C, we are not usually afraid of the flare. Flare could occur in hepatitis B virus, and especially if patient is having COVID-19 and we are treating them with immunosuppressant drugs, with high-dose steroids, there is likely chance of having a flare, and this flare could lead to a reactivation of hepatitis B virus, and that could lead to an acute liver failure and complication, and death could occur. So flare may occur in hepatitis B surface antigen negative patient who had only the core. So if there is an unexplained elevation in liver biochemistries, bilirubin and INR, we need to consider to check for core and to assess for hepatitis B flare in this individual. So hepatitis B flare with new drugs with immune suppressant could occur. If the patient has no COVID-19, newly diagnosed chronic hepatitis B, we need to treat them. Adverse outcome in advanced hepatitis B and hepatitis C virus liver disease should also be treated. COVID-19 patients in general, if they have abnormal hepatic biochemical tests, it could be part of systemic illness, as I mentioned. It could be immune-mediated. It could be direct cytopathic effect of the virus. Other infections apart from hep B and hep C should also be looked up and worked and identified. It could be also drug-induced, and ischemic hepatic injury due to ischemic reperfusion injuries could also occur. There are guidelines for drug-drug interactions that can be seen when new drugs are also instituted in patients with this COVID-19, and we also need to look when to stop when you start, because this COVID-19 is new and new treatment could be instituted, and when these new drugs are instituted, we need to know when to stop due to the severe liver injury, especially, for example, remdesivir has been known to have drug-induced liver injury, and we should know when to stop when patients having like a grade 5 toxicity or so. And reactivation of hepatitis B related to therapies, as I've said, prednisolone, and also tocilizumab. These biologic agents, immunosuppressants, steroid high dose, lead to reactivation of hepatitis B. It should be treated, otherwise patient could die of the complications of reactivation. So the future perspective and final recommendation is hepatitis B as is a neglected yet preventable and treatable virus. We need to consider cirrhosis as a high-risk comorbid condition in COVID-19. And routine screening for viral hepatitis in COVID-19 patients is important to find them. And we need to validate the potential of drug-drug interaction with new drugs and also potential for drug-induced liver damage. And I would like to end up considering hepatitis B and also even considering COVID-19 because both diseases are preventable diseases. If we prevent them, then we can avoid the deleterious consequences. So WHO Director Dr. Tedros Adhanom has said in WHO 70, countries must invest in programs that keep people healthy and out of hospitals. Prevention is not only better than cure, it's cheaper. So thank you for this opportunity. And this is my email address for any further contacts or any questions.
Hello, doctor.
Hello.
I've put the questions from the audience in the chat box. If you can read them and answer them, that'd be great.
Okay, I haven't seen any.
In the chat box, or okay, I'm going to send them again.
Okay.
Are you seeing them now? Hello?
And answer them, that'd be great.
Hello, doctor.
Hello.
Yeah, we can hear you, doctor.
Okay, I was trying to answer the questions through text. Can you hear me? Hello?
Yeah, yes, we can.
Yeah. So,
Going to send them again.
okay, thank you for the question. So one question which I found is from the Solar D. So his question is, what are the possible effects of COVID-19 on patients with hepatitis in general?
Are you seeing them now?
Yes, yes.
Hello?
Yes, I'm trying to answer from the YouTube. Yes. So COVID-19 in general. Hello, can you hear me? Hello? Hello? What's happened? Hello?
Hello, doctor. I can hear you. Go ahead.
Okay. So from the YouTube questions that I have seen, one of the questions was the possible effects of COVID-19 on patients with hepatitis in general. So as I have tried to mention here, COVID-19 has also direct effects on the liver. So patient with hepatitis B infection, just hepatitis B alone, without development of cirrhosis, has not been shown to have an increased chance of acquiring COVID-19 or complications. But once they have chronic liver disease and cirrhosis, as I have said, the different studies have shown that they will have a poor prognosis, like 13% mortality versus 30% if the patient have cirrhosis. So it increases the mortality risk once the patient have also cirrhosis and COVID-19. Transmission with body fluid like sweat, urine, and the others has not been considered an important mode of transmission for hepatitis B virus, as different studies haven't shown any. Considering this question from Salam Mubshat, hepatitis B and D, it's good to ask about these co-infections because hepatitis. Hello.
Yeah, we can hear you, doctor.
Okay, I was trying to answer the questions through text. Can you hear me? Hello?
Yeah, yes, we